Hyperthyroidism Thyrotoxicosis. You are looking for accurate pieces of information on both or just one of these two, you're in the right place. Without much ado, I'll go straight to full pieces of information on hyperthyroidism and thyrotoxicosis. And if anyone is wondering, why will you combine the two? They are not far apart, and they are closely related. The differences between them, I'll point them out right here. Okay, let's go. Here is a quick definition. Hypothyroidism is the excess synthesis and secretion of thyroid hormones from the thyroid gland. While thyrotoxicosis is all about the signs and symptoms of the high level or of the excess thyroid hormones in the circulatory system, regardless of the source or sources. Do you want me to explain here? Hyperthyroidism means the thyroid gland is hyperfunctioning. It is synthesizing in excess, it is secreting in excess of the hormones from the thyroid gland. While thyrotoxicosis will let us know what is happening here, that something is beyond the normal level, but it might not be limited to what is happening within the thyroid gland alone. Once we have excess thyroid hormones in the circulatory system, there will be signs, there will be symptoms. Thyrotoxicosis will not give you the clue that it is only the problem within the thyroid gland. It can be from anywhere that the thyroid hormones will come from. Don't worry, you will see everywhere that we can pick ectopic thyroid tissues where thyroid hormones can be secreted outside thyroid gland. I think that explains this. Hyperthyroidism, the thyroid gland is hyperfunctioning, synthesizing more, secreting more. While thyrotoxicosis is all about signs and symptoms of high level of thyroid hormones in the circulatory system. Now, don't let us muddle up things. Let's now get down to the bus stop of hyperthyroidism alone. We will later drive to the bus stop of thyrotoxicosis, but let's park right now. Let's get down from our car and enter into the grotto of hyperthyroidism. What is this all about? The journey into full understanding of hypothyroidism will be better if we start with Neuro-Endocrine System flashback on hypothalamic pituitary thyroid axis. The hypothalamus here will be releasing thyrotropin-releasing hormone. And what would that do? TRH will stimulate the anterior pituitary. Why am I limiting myself to anterior pituitary? Because that is where the thyroid stimulating hormone will come from, and then will act on the thyroid gland to produce tyrosine. So the posterior pituitary is not our business today, it is the anterior. Later on, when we have to do anything with oxytocin or antidiuretic hormone, we will then be talking about posterior pituitary. For now, hypothalamus to anterior pituitary to thyroid gland. But the T4 is not that very active biologically. It can exert some low level of biological activity. As a matter of fact, so many literature, sources will put it as inactive thyroid hormone, that it can actually exert some level of biological activity, very low anyway. The active form is the T3, triiodothyronine, but we can only get that. We can get T3 also from thyroid gland, but in a low concentration. 90% of the thyroid hormones that will be secreted, will be T4. So T4 will be peripherally converted to T3. We'll get into all this in a bit. So the journey has started to T3 from T4 after TSH has acted on the thyroid gland. The TSH is being produced from the pituitary when TRH has been sent from the hypothalamus. Okay, we've just gone through how the brain can serve as the master controller of thyroid hormone synthesis from hypothalamus to the pituitary to the thyroid gland. So what is the relationship between the two hormones from the thyroid gland itself? The tyrosine in the highest percentage, 90%, the T3 just about 9%, and then reverse T3, less than 1%. So what is happening? What's the relationship between them? Let's go. T4. T4 is the largest thyroid hormone secreted by the thyroid gland. I have said this repeatedly within the last 6 minutes. T4 is about 90% of the thyroid hormones that will be secreted by the thyroid gland. It is not biologically active very strongly, no. It should be converted to T3 in peripheral tissues like the liver, the brain, and the kidneys. It is believed to be inactive, but can also trigger some, not much, biological activity. It is an inactive prohormone that has 4 iodine atoms. Free T4 level is the first to show that there is a lesion or there is none or there is any anomaly with the thyroid gland. Let me repeat this. Free T4 level is the first indicator when we are doing thyroid function test to depict exactly that the company is shutting down or the company is hyperfunctioning, meaning the thyroid gland is shutting down or the thyroid gland is overworking. The level of T4 will tell us, because many things could happen to T4 conversion to T3 outside the thyroid gland, and the value of T3 will be determined by all those factors. Don't worry, we'll get into that in a bit. T4, therefore, is the one and the most important factor to look for when we are worried that the thyroid gland is in trouble. So T4 is the one that must be measured. If we don't have time to measure T3, that's fine. Now T3. Some T3 are also produced directly by the thyroid gland. Let's take that, but very low, okay? Just less than 10% of the total thyroid hormones that will be synthesized and secreted. T3 is also produced, but very low. T4 mostly. Larger proportion of T3 is from peripheral conversion of T4 to T3 by deiodination, that is extrathyroidal production. So it's like a child claiming to be better than the mom, but without the mom carrying the pregnancy to term and having the delivery, how could the child come to the whole world? No way. So T3 is from T4. Without T4, there'll be no T3. Although T3 is now the one we recognize because it's the one that is most active biologically, and that is the one we'll be referring to when we reach the burst of thyrotoxicosis, because that is one that will give us the signs and symptoms that will lead us to run for safety or rescue. T3 has 3 iodine atoms. From 3, you should understand that elementary mass, hence triiodothyronine. It is the biologically active thyroid hormone, and it will do that by binding to thyroid hormone receptors. T3 is the main inhibitor of thyroid-stimulating hormone secretion, the feedback. In hypothyroidism, decreased activity of the liver, the gallbladder, will hinder T4 conversion to T3. You see, I've just said that in the last 4 or 5 minutes that we cannot blame thyroid gland for the value of T3. When we want to blame thyroid gland for the value of thyroid hormones, let's check for the value of the T4. So now the picture is there. There is T4, okay, in some cases of hypothyroidism, but because the peripheral conversion is in trouble, liver is sick, gallbladder is sick, sometimes the brain, even some level in pituitary, and so on. We will see all of them very soon, and even kidney. Then the conversion to T3 would not be good, and if it's not good, signs and symptoms of the level of thyroid hormones will not be that of hyperthyroidism or euthyroid. It will be signs and symptoms of hypo because T3 is low. So we have enough T4, but thyroid gland is not the one sick, but the liver is sick, the gallbladder is sick, kidney is sick, and the brain is sick, some part of the pituitary gland is sick, and then we'll be having hypothyroidism. T4 to T3 conversion. Extrathyroidal conversion of T4 to T3 is affected by many things. 1. Fetal status, nutrition, certain hormones, illness-related factors, diseases, and many medications. Because we'll still touch this later, I will not waste the time right now. But this has confirmed what I've said just a while ago. You might have enough T4 and you will not have enough T3 if things are not normal in the body outside the thyroid gland. And then you will not have the effect of T3. So it will appear as if the thyroid gland is not working. It's actually working. Enough T4 already being synthesized and secreted, but conversion to T3 is not happening. So we're in trouble. Now, T4 to T3 conversion in non-thyroidal tissue is regulated. Oh, great. Where there is no regulation, people do anything they like, right? There is regulation. And how? A process that will convert T4 to T3 will be catalyzed by T4-5 dehydrogenases, or known as tyrosine 5 dehydrogenases. These will be predominantly found in the liver and the kidney, but that is not the only place we can find them. The tyrosine 5 dehydrogenase will be divided into 2 groups. Type 1 will be found in the liver, in the kidney, and the thyroid. Type 2 will be found in the brain, pituitary, and the skin. You can see, so when we have problem in the liver, kidney, thyroid, brain, pituitary, and skin, it can bounce back and we will have signs and symptoms of hypothyroidism. Why? T3 will not be made from T4 adequately. Now, type 1 dehydrogenase will be ineffective. In other words, what I'm about to say is that in these conditions, the conversion of T4 to T3 through type 1 dehydrogenase protease will not be happening. In fetus, in hypothyroidism, starvation, in diabetes mellitus, in uremia, in propylthiouracil. Meaning when you give a propylthiouracil, you are blocking this. When there is uremia, you are blocking this. When there is diabetes mellitus, or you are starving that child, or there is hypothyroidism already, or the fetus in the month, this is inactive. Now, still on type 1, amiodarone, glucocorticoids, beta blockers, and reverse T3, all in the liver, kidney, and thyroid, will make type 1 dehydrogenase to be ineffective. Hence, there will be no thyrotoxicosis. Now, type 2 dehydrogenase will be ineffective or inactive in fetus in hyperthyroidism, in amiodarone, in the brain, pituitary, and skin. The activities of both types 1 and 2 will be greatly enhanced or increased in certain situations. For type 1, the enhancement or increase in activities will occur in the face of hyperthyroidism, in glucose with insulin administration, and high caloric foods, while that of type 2 will be greatly increased or enhanced in hypothyroidism. So, non-thyroidal illness and medications can affect T3 production. Both T4 and T3 will bind to something. They will both bind to tyrosine-binding globulin, transthyretin, and albumin. They form the circulating storage pool, while the unbound is free for reuptake. T3 occupies specific nuclear receptors with B1 in the brain, in the heart, in the liver, and the kidney, while B2 will be found in the pituitary, hypothalamus, retina, and the ear. The thyroid stimulating hormone. These we've gone through right from hypothalamic pituitary thyroid axis that TSH will come from the anterior pituitary. That will stimulate all the steps in thyroid hormone synthesis and secretion. It's going to stimulate intermediary metabolism and also stimulate expression of many genes in the thyroid tissue. It can cause thyroid hyperplasia and hypertrophy. That is not far-fetched, right? When something is stimulating activities within a gland, then the gland will be, getting enlarged and enlarged. Still on TSH, actions are initiated by binding to specific plasma membrane receptors. It can initiate activity of adenylyl cyclase, increasing cyclic adenosine monophosphate, and the cyclic adenosine monophosphate will in turn activate several protein kinases. It can stimulate phospholipid C activity in thyroid tissue and also increase intracellular calcium ion concentration and protein kinase C activity. Now, hyperthyroidism and thyrotoxicosis, we want to look at how they are related, okay? We're seeing what is happening when we say the word hyperthyroidism, although we will still go over thyrotoxicosis separately, but is there any link, any relationship, anything similar or different between the two? So let's go and check out the similarities and contrasting features. Are they monozygotic twins? Someone is asking me. You are talking about thyroid gland. You are asking me a question that is related to OBGYN. Medicine is interrelated, okay? So, we understand what the monozygotic twins is all about, right? Hyperthyroidism and thyrotoxicosis is not quite monozygotic, but they are very, very close. They are related. Let's see. Now, the differences between them is that thyrotoxicosis is all about signs and symptoms that are due to the effects of the excess thyroid hormones from the thyroid gland or the ectopic foci like Struma ovary or exogenous intake of the thyroid hormone, like intake of levothyroxine in the treatment of hypothyroidism and so on. Don't worry, we'll get all this in a bit. While hyperthyroidism means thyroid gland is hyperfunctioning, is overactive, as by the increased production leading to the hypermetabolic state known as thyrotoxicosis from diffuse toxic goiter, like Graves' disease, or toxic nodular goiter, which is known as Struma disease, or could be from toxic adenoma. Now the differences, and that is where we are really going, okay? Hyperthyroidism will lead to thyrotoxicosis, but thyrotoxicosis cannot lead to hyperthyroidism. A mother can give birth to a child, the child cannot give birth to the mother. So in this case, hyperthyroidism is like the mom who has given birth to the troublesome child known as thyrotoxicosis. But the thyrotoxicosis cannot go the other way around to cause hyperthyroidism. Okay? Thyroidectomy may cure hyperthyroidism if the problem is limited to the thyroid tissue and it has been removed. They'll be cured. And then profound hypothyroidism, but may not cure thyrotoxicosis. You're asking me why? I should be asking you. The reason is that I've said this in the last 20 minutes, that thyrotoxicosis is the signs and symptoms of excess level of thyroid hormone, specifically T3. Okay? Reverse T3 is inactive. T4 is not biologically so active. So the bulk of the concentration will now be on T3. That T3 is responsible for thyrotoxicosis. But remember I said, T3 may not be as a result of what is happening within the thyroid gland. T3 can come from the ectopic thyroid tissues outside thyroid gland. So that is the reason why if you then put your knife on the anterior neck and you scoop off the entire thyroid gland, when the overproduction of T3 is actually coming from Struma ovary and other ectopic sources, then the woman is still there, or the man, many women, some cases in men also, will still not get out of thyrotoxicosis. So thyroidectomy will likely cure hyperthyroidism if you are lucky enough to remove the entire thyroid gland in the face of hyperthyroidism. But remember, pyramidal lobe. Remember to remove the pyramidal lobe as well. Now, the similarity is that FAS are common to both of them, and both of them will have high level of thyroid hormones. So hyperthyroidism, IT4, IT3, T3 may be low if there is problem with peripheral conversion. Okay? But you can have thyrotoxicosis without a high level of T3. And how will you get high level of T3 without high level of T4? T3 that is produced even in thyroid gland is less than 10% or at most 10%. Both will alter the normal metabolic processes in the body, because once there's hyperthyroidism, then the signs and symptoms will be thyrotoxicosis. That will be altering metabolic processes. Treatment of both is similar, with most medications that are helpful here. Treatment may be slightly different. Why that? The source of sources are not rigidly the same. I will not waste your time going over and over again. So also will the treatment be, because it may differ slightly. Let me give an example. Exogenous levothyroxine is not from the thyroid gland. The pharmacists, they've helped us. They've been saving lives, and they are not tired. We are grateful to them. So they are here with the levothyroxine. That is not from the thyroid gland. So if you administer that, you may enter into thyrotoxicosis without hyperthyroidism. The thyroid gland is not hyperfunctioning, but there is thyrotoxicosis. So the treatment here is simple. Just have a way of reducing or regulating that exogenous tyrosine, and then you are out of the problem, you are out of the wood, because it is exogenous that is causing the thyrotoxicosis, which will not cause hyperthyroidism. Ectopic or exogenous sources in thyrotoxicosis may alter the surgical intervention pattern. And do you need to ask me any question here? No. Meaning you don't need surgery. All you need to do is, young woman or man, please, we'll do something about the level of T4 you are taking. If it's 50 microgram, we'll be taking it off gradually. No, we don't stop any medication, cold turkey. Now, thyrotoxicosis. So if you have come to visit my channel and you click on this because of thyrotoxicosis alone, then you are at the bus stop right now. We'll get down and get thyrotoxicosis. Thyrotoxicosis, you can see as this is bubbling, it will be bubbling like that in the entire system. The entire metabolic processes will be affected and everything will be at a high level. Remember, hypothyroidism, everything is low. Everything is low, except the hypercoagulable states, except the excess bleeding. The rest, decreased heart rate, decreased ventilation, decreased electrolytes, decreased everything. By definition, thyrotoxicosis is all about the clinical signs and symptoms of excess or high level of circulating thyroid hormone. It may be due to excess synthesis and secretion within the thyroid gland, which is hyperthyroidism, or completely outside the thyroid gland, or due to destruction of the thyroid gland that will lead to more thyroid hormones being released momentarily. Epidemiologically, thyrotoxicosis occurs in 1 to 2% of women and in 0.1% of men. There's excess T4, T3, and low TSH. Increase in all metabolic activities will be the case here, and the individual could become irritable. Female to male ratio is 5 to 1 respectively, more in older women, more in smokers. Graves' disease will be the source in younger women, while toxic nodular goiter will be found more in older women. I think this is self-explanatory, right? Now, we'll be going through causes of thyrotoxicosis. We've known the definition of thyrotoxicosis, what it's all about, but what is causing this? Why do we have it? Let's go. The commonest cause will be hyperthyroidism. All causes of hyperthyroidism can cause thyrotoxicosis. Now, Struma ovary is a rare ovarian tumor. It is made of at least 50% thyroid tissue and can cause increasing in the level of thyroid hormones. So, we are out of the thyroid gland, but we are not out of thyrotoxicosis because this, the ovarian tumor, cause Struma ovary can cause high level of thyroid hormones. Basically, there are two broad ways to hypothyroidism. It is either hypothyroidism is with a normal or high radioiodine uptake, and that will be pointing to the fact that the problem is within the thyroid gland itself. Or it might be that we will be dealing with close to absent radioiodine uptake, and that will be pointing to the fact that there is inflammatory process and destruction of the thyroid gland has occurred, and that has led to the release of the already formed hormone and is getting into the circulatory system. It could also be an extrathyroidal source of thyroid hormone. Graves' disease. Graves' disease is the commonest cause of hyperthyroidism. If you've not learned anything today, please take that home. Graves' disease is going to be occurring in people less than 40 years, so in younger age group. It is an autoimmune disorder. In Graves' disease, here the thyroid stimulating immunoglobulin will bind to thyroid stimulating hormone on the receptor cell membrane, and that combination will be leading to excess synthesis and increased secretion of the thyroid hormone. It will also stimulate the thyroid stimulating hormone receptor. Ectopic hyperthyroidism. Ectopic hyperthyroidism will be either from Struma ovary, like I've explained earlier, that is a rare ovarian tumor where 50% of it forming thyroid tissue and have the capability of secreting thyroid hormones, or metastatic follicular thyroid cancer from ectopic hypothyroidism. Now, another cause of thyrotoxicosis is exogenous thyroid. Here, exogenous thyroid hormone intake is the problem, and it is either as a result of excessive replacement therapy or the individual has intentionally ingested excess thyroid hormone, okay? And it might be factitious hyperthyroidism. Don't worry right now. We will get into that separately. Exogenous thyroid. Sometimes while treating hypothyroidism with T4, that is levothyroxine, we can inadvertently tilt the patient to thyrotoxicosis if we prescribe excess dose. That is why it is wise to start low, and once we are winning, we don't go up. So it might be inadvertently, iatrogenic, maybe intentional by the user. When the physician has prescribed 12 microgram per day or 25 microgram per day, because I'm not comfortable with that dosage of levothyroxine except in children. And of course, we have to get our calculator and weigh them, 10 to 16 microgram per kilogram per day. So some will intentionally take excess of it. T4, when it is given to suppress thyroid stimulating hormone in thyroid cancer, or thyroid stimulating hormone to decrease the size, then while doing that, we can tilt the patient to thyrotoxicosis. But sometimes it's not, because prescription has been made, you are treating, and then, high dosage has been prescribed, or patient has taken excess, it might be accidental. Bottle or the container of the levothyroxine is placed near somewhere, particularly in children. Then they grab it and swallow. They have a problem. Serum thyroglobulin. Serum thyroglobulin is a protein produced by the follicular cells of the thyroid gland. Iodine is combined with thyroglobulin to form thyroid hormones T4 and T3. Whatever leads to the increase in the size of the thyroid gland will lead to an increase in the value of serum thyroglobulin in thyroid cancer and Graves' disease, in nodules or iodine excess or deficiency. Usually, the serum thyroglobulin is between 2 to 40 nanogram per ml in a healthy person. Now, thyroglobulin again is a glycoprotein produced by follicular cells of the thyroid gland. It's the main precursor to the thyroid hormones. Thyroglobulin is tyrosine with iodine and then will later cleave. Tyrosine iodination is catalyzed by thioperoxides in the follicular colloid. So, thyroglobulin will act as a substrate for the synthesis of the thyroid hormones. T4 and T3 as tyrosine and triiodothyronine respectively. The inactive thyroid hormones and iodine are stored within the follicular lumen. T3 and T4 are attached to thyroglobulin and form the colloid within the follicle. TSH will lead to the cleavage of the colloid by proteases to release thyroglobulin from its T3 and T4. T4 and T3. T3 and T4 are released in the circulatory system. Thyroglobulin is recycled back into the follicular lumen to be used again. T3 and T4 can be unbound or bind to plasma proteins. Factitious hyperthyroidism from the English word is pretty clear. Here there's an exogenous thyroid hormone. This is a deliberate attempt created consciously by taking the tyrosine. Factitious ingestion will have a serum thyroglobulin values that are either very low or undetectable. Why? Because it has not passed through the process that will warrant thyroglobulin binding and cleaving and then releasing the T3 and T4. We have T4 or we have T3, but there is no thyroglobulin. But in other causes of thyrotoxicosis, serum thyroglobulin will be raised. Because if you pause and rewind back, serum thyroglobulin level is expected to be raised because it will be involved in the process of the thyroid hormone synthesis. Human chorionic gonadotropin mediated hypothyroidism. I know HCG is not new to you, but what is new now is whether it can lead to hyperthyroidism. And let's go. Now, pregnancy with hyperemesis gravidarum leading to preterm birth, low birth weight, or pregnancy-induced hypertension will be, part of the signs and symptoms with this type of hypothyroidism, if it is coming from human chorionic gonadotropin. And we are likely going to find this in trophoblastic disease. Why that? Trophoblastic disease will be characterized by a very high level of human chorionic gonadotropin. And needless to say, that is going to be found mostly in women. The reason is that human chorionic gonadotropin can stimulate the thyroid gland to start producing its hormones. I think it is now clear, right? HCG, when it is high, there's likelihood of hypothyroidism. And we are going to find HCG that is high in pregnant women with hyperemesis gravidarum in them, leading to effects on both the mother and the baby. And then also, even if the woman is not carrying a viable fetus, might be as a result of trophoblastic disease with a high level of chronic gonadotropin. It's also found in men when they have certain cancer. The reason is that chronic gonadotropin will stimulate the thyroid gland to be producing its hormones. Another cause of hyperthyroidism that could lead to thyrotoxicosis is thyroiditis. Here is self-explanatory, right? Inflammation of the thyroid, meaning the thyroid gland. And it's like something is in the bag, okay? And then you are puncturing and beating and hitting the bag. The content inside the bag, when you have cut it open and particular edge or so many edges, will be seeping out to the environment. So exactly that's what's happening here. Might be subacute granulomatous thyroiditis, lymphocytic thyroiditis, silent thyroiditis, or postpartum thyroiditis, or because you've taken amiodarone, or there is radiation somewhere. Another one is thyroid-stimulating hormone-mediated hyperthyroidism that could lead to thyrotoxicosis. In this case, the thyroid-stimulating hormone is caused because there is pituitary adenoma that is producing thyroid-stimulating hormone. It is non-neoplastic thyroid-stimulating hormone-mediated hyperthyroidism. Another problem is iodine. So hyperthyroidism can be induced by iodine. And when there's hypothyroidism, there's likelihood of thyrotoxicosis. Okay, what about autoimmune conditions? Yeah, you can have autoimmune thyroiditis. It is worse in smokers. And here we have Hashimoto's thyroiditis or Graves' disease. One can evolve to the other, back and forth. Also, goiter. It might be toxic multinodular goiter leading to hypothyroidism, or toxic single nodal goiter in regions with decreased iodine, and the likelihood will increase with age. There may be toxic adenoma, which is a benign secreting thyroid tumor. In toxic nodular goiter, there will be benign monoclonal thyroid tumor, autonomously secreting excess thyroid hormones. It can be a single nodule or a multiple nodule known as multinodular goiter. It is known as toxic multinodular goiter or plumar disease. Hyperthyroidism could be caused by drugs leading to thyrotoxicosis. Here we have the list of many drugs like tyrosine kinase inhibitors. I've given examples here. Could be lithium, could be immunotherapy with interferon alpha, nivolumab, pembrolizumab, or ipilimumab. Epoprostenol, that is very helpful in handling pulmonary arterial hypertension, could also be responsible, but we should know it is a prostaglandin. Might be as a result of metastasis to the thyroid gland. There is an entity known as Thyrotoxicosis. Here, acetoxicosis will combine Hashimoto's and thyrotoxicosis. So, an individual with Hashimoto's thyroiditis at the early part of the insult, scooping into the thyroid gland and sending the thyroid hormones into the circulatory system can have thyrotoxicosis. So, Ashi from Hashimoto's, toxicosis from thyrotoxicosis, so acetotoxicosis. Now, thyroiditis. Here there will be decreased radioiodine uptake, and there will be painless lymphocytic thyroiditis. Common in postpartum thyroiditis, and the inflammatory process would have destroyed the thyroid gland. Still on thyroiditis, there will be transient mild thyrotoxicosis from the release of thyroid hormones. Like I've explained earlier, there is going to be scooping of the thyroid gland, and then the inflammatory process that is doing that will send the thyroid hormones into the circulatory system. After sending the stored hormones into the circulatory system, then there will be depletion of the thyroid hormone. Also, atrophy of the thyroid gland. So there will be no more thyroid goiter, and the volume and the quantity of thyroid hormones will also drop. There is that possibility of normal functioning gland in 80% of affected people after the cessation of the inflammation. Now that may span the period of 1 to 2 years. So the long and short of it is that in thyroiditis, there will be transient thyrotoxicosis, because when the inflammatory process would have eaten up the thyroid gland, the hormones will be released. It's like it's piercing the gland, and then the content is seeping out into the circulatory system. And when that has been done for a while, there's nothing more to send, then there will be hypothyroidism. Okay, and some people will actually have euthyroid at a time. In subacute thyroiditis, there will be raised erythrocyte segmentation rate, C-reactive protein, and they will have painful anterior neck, and this is the common cause of thyroid pain, subacute thyroiditis. It could have viral cause, and in most cases, it's self-limiting. Subacute thyroiditis will have the following clinical features. There may be acute fever with severe neck pain, and the clinical features of thyrotoxicosis will appear first. If you want to know the signs and symptoms of thyrotoxicosis, you just wait a little bit. We'll get into that. Also, clinical features of hypothyroidism will then follow after. Cold intolerance, constipation, bradycardia, everything is low in them, sluggishness, and so on. So all this will follow when the thyroid hormones would have been depleted in the thyroid gland. And then when all this drama will be over, there will be normalcy. So the situation will return to normal. Later on, there will be increased ESR and C-reactive protein. Now, thyroid storm. Well, this is ironical because there's celebration here, but unfortunately, there's no celebration in anyone having thyroid storm. It is a storm. It's a hurricane. It's a tornado. It is tsunami. It's horrible. It's scary. It's killing. Thyroid storm. So, do we need to get out of our vehicle right now and enter into the storm? Yeah, I think we should. So let's get in at this bus stop and find out what is happening when we hear the word thyroid storm. Okay, by definition, thyroid storm is a life-threatening medical condition with exaggerated symptoms of thyrotoxicosis. So you see, here's the problem. Thyrotoxicosis is not friendly. It's a very terrible condition. Now, it is exaggerated here, so it is above thyrotoxicosis, so to speak. You can check my channel here for complete note on thyrotoxicosis already published by me, but don't worry, if you don't have the time to do that, you are still going to get it here today, because I'm going through A to Z when it's all about hyperthyroidism and thyrotoxicosis, so I'm still going to repeat it. However, there's a light right there at the end of the tunnel. And what do I mean? Thyroid storm is a rare condition. The risk factors for thyroid storm will include long-standing hypothyroidism, untreated hyperthyroidism, Graves' disease, toxic multinodular goiter, solitary Tosic adenoma, thyroid surgery or non-thyroidal surgery, of course trauma or infection. Others include acute iodine load, parturition, sudden stoppage of antithyroid medications, increased C3 and T4, and decreased thyroid stimulating hormone. Symptoms and signs will include severe nausea, vomiting, and diarrhea, tachycardia, hypotension, arrhythmia, with or without atrial fibrillation, congestive cardiac failure. Others include hyperparesia, agitation, anxiety, delirium, and psychosis. In addition, there may be abdominal pain, hepatic failure, jaundice, of course, when there is a hepatic failure, right? Altered level of consciousness, stupor, coma, and death. So, in summary, thyroid storm can kill. It's pretty horrible. On physical examination, when it comes to hypothyroidism and thyrotoxicosis and thyroid storm, there may be goiter, there may be ophthalmopathy, particularly in Graves' disease, lead lung, hand tremor, dermopathy, warm and moist skin. Remember what you're going to pick in hyperthyroidism, right? And how to make the diagnosis? The diagnosis will involve all of what we've gone through above, like the features, the signs on physical examination, the symptoms, and all those signs that we're going to pick while the patient is with us. Then we take a complete history, thorough and complete physical examination, and could be focused physical examination on thyroid related diseases. Thyrotropin receptor antibodies when we have the lab to help us out, and radioiodine uptake and ultrasound of the neck. When the result is out from the lab, we are likely going to find low level of TSH, increased T4 with increased T3, with increased glucose, increased calcium, increased white blood cell count, and you may have decreased white blood cell count. Increased metabolism of medications will be the case here. Why that? Hyperthyroidism will increase metabolism of medications. So you have to give a slightly higher doses when there is hyperthyroidism and you want that medication to be effective. But be careful. If it is a dangerous drug that a little bit of higher level could cause so much damage, then you have to monitor for the value or the level or therapeutic level of that very medication. Please watch out. But yeah, I wrote here, watch out for the side effects of the medications you are given. So this has not opened the window to overdose anyone, please. Now, treatment. How do we treat thyroid storm? First thing first, admit. Admit where? Not just anywhere, but intensive care unit. Check the airway. Any foreign body, any secretion, function as it is appropriate. Then make sure the airways are patent. Then breathing. What is the respiratory rate? What's the O2 sat? Any obvious deformation of the chest region, any deviation of the trachea, cyanosis central or peripheral, any finger clubbing right now, then auscultate for the air entry, either decrease or not. You may cause for dullness, stoning dullness, crackles, and auscultation, and so on. Then the circulatory system, what are the vital signs right now? Was the blood pressure? Was the heart rate or pulse? then any capillary refill delay, fluid in and out, signs of dehydration, skin turgor, and so on. IV fluid, set 2 lines, please. And you can give IV fluid, but you may need diuretics if you are battling with congestive cardiac failure. Remember, part of the signs and symptoms will include congestive cardiac failure, but not in everyone. But whoever has it, then your IV fluid will just be to keep the vein open, and you give your diuretics, but watch out for the electrolyte imbalance. Treat any identified etiology like infection. Then let your Foley's catheter, that is bladder catheterization, be in situ. With that, you want to monitor both fluid in and fluid out. Radioactive iodination. Iodinated radiocontrast will be helpful to prevent the conversion of T4 to T3. Let me explain here. Remember, I've said earlier that the thyroid gland is capable of synthesizing and secreting thyroid hormones. That is T4, that is going to form about 90%, while T3 will just be about 9%, and then reverse T3 will just be less than 1%. So in that case, only few T3 will actually be produced directly by the thyroid gland. Peripherally, T4 will be converted to T3. Once we give radioactive iodination, the peripheral conversion of T4 to T3 will become impaired. The reason why I've taken 1 minute to give this explanation is that radioactive iodination is the best treatment for hyperthyroidism, thyrotoxicosis, and thyroid storm. Why that? We are preventing further conversion of T4 that is biologically inactive to T3 that is biologically active and is the one giving us these signs and symptoms that we are battling with right now. So when less of T3 is in the circulatory system, we're blocking T4 right there to remain inactive, then we're fine. So we can also go for iodine solution to block further hormone synthesis. I've just told you that we can prevent T4 from being converted to T3, radioactive iodination, right? Now we want to even prevent T4 being produced from the beginning. So iodine solution to block further hormone synthesis. Keep glucose solution till 1 hour after the administration of propylthiouracil, meaning propylthiouracil should be given first. An hour after, you can give your glucose solution, but I will talk more about glucose solution later on, so I don't want to waste your time yet. Beta blocker like propranolol will be helpful. It's not going to deal with hormone synthesis or conversion of T4 to T3. It will just going to handle adrenergic symptoms like tremor, tachycardia, or if there's atrial fibrillation already, well, to some extent it will help. Then metoprolol will be good in heart failure and also in tachycardia, but propranolol will be better in tachycardia. Digoxin for heart failure and as well as atrial fibrillation. So arrhythmia and heart failure, if they're already present, digoxin will be helpful. So all these medications are helpful, but it depends on what we have at hand. Thionamide, yes, the main drug in the phase of hypothyroidism. But remember the journey before reaching here. So it's not enough to just grab propylthiouracil, methimazole, or carbimazole, and then think, oh, we're done. No. We could see what we've done before reaching here. So propylthiouracil, there are certain situations where and when we cannot use it. Methimazole, carbimazole, I'll go into that later on. they are meant for new hormone synthesis inhibition. So we don't want new T4 or T3 to be produced. And when we don't have more new T4, then conversion of T4 to T3 peripherally will be blocked. Propylthyroidism is better in decreasing T4 to T3 conversion. Great. Propylthyroidism and metimazole can be given superficially, or propylthyroidism could be given by retention enema. Still on the treatment, we can grab our glucocorticoids. Glucocorticoids will decrease conversion of T4 to T3 and promote vasomotor stability, decrease autoimmune process found in Graves' disease. In fact, if anyone should forget what glucocorticoids would do in hyperthyroidism or thyrotoxicosis or thyroid storm, remember that it has the capability of stopping the autoimmune process. That is it. As a matter of fact, in thyroiditis, we go for glucocorticoids to stop that heavy bombardment of the thyroid gland by the inflammatory process, inflammatory cells. So also when there is a central problem affecting the hypothalamus and pituitary, then we can be envisaging that there will be a problem with adrenal gland as well, leading to adrenal insufficiency. Remember, Neuro-Endocrine System with hypothalamic pituitary thyroidal axis, hypothalamic pituitary adrenal axis. This time around, this is adrenal axis, right? So in adrenal failure, adrenal insufficiency, glucocorticoids will be pretty helpful. Now, still on treatment, bile acid sequestrants will be helpful. And someone is asking, what's the business with bile acid sequestrants here? Well, example is cholestyramine. And what it will do is it will prevent enterohepatic circulation of thyroid hormones. Remember, peripheral conversion of T4 to T3 can occur in the liver. So that will be blocked here. Plasmapheresis is meant to remove cytokines, antibodies, and thyroid hormones from the plasma. And lithium can also block the release of thyroid hormone, but it is seldomly used due to toxicity. See, sometimes the dog will have its day, right? Lithium is a bad medication for thyroid gland because it will block the release of thyroid hormone, giving us hypothyroidism. But in this case, that is exactly what we want. We don't want more thyroid hormones being released into the circulatory system. So we want to block it. But we need to be extra careful. Lithium itself has a lot of baggages, okay? Baggages, right? So a lot of issues associated with lithium, and lithium toxicity on its own could be detrimental. So we'll be careful when we're using lithium for this good purpose anyway, right here. And most of us will not go for that. Calcium channel blockers will handle rate control in asthmatic but not in heart failure. Why did I put it this way? I will not be comfortable to use calcium channel blockers in heart failure. But in asthmatic patients, where I will be extremely careful to use non-selective beta blockers, because when I block beta 2, asthmatic patients will suffer greatly. They will suffer immensely. So I would rather go for calcium channel blockers to deal with that in asthmatic patients. But when there's heart failure, I will not go for calcium channel blockers. Propranolol can actually inhibit Now, type 1 dehydrogenase, which can lead to a reduction in T3 levels. So propranolol has multiple effects. There you go. Propranolol is not only going to handle the tremor, but at the same time can prevent peripheral conversion of T4 to T3, at this level. Okay, with that, I've come to the end of thyroid storm, but I've not come to the end of this journey. We are still traveling together. Let's move on. Okay, the signs and symptoms of Thyrotoxicosis. Signs are what the physicians and the nurses will pick, while the symptoms are what the patients will tell us that they have been passing through. The patient will say, "Oh, I feel this way, I feel that way, it's like this for me," and then the nurse will check, the doctors will check. What the doctors and nurses will pick are signs. What the patient will tell us are symptoms. When it comes to thyrotoxicosis, let's examine what we're going to pick. Now, signs and symptoms of hyperthyroidism will be leading us to thyrotoxicosis. It's going to be the same. Adenitis symptoms. Adenitis symptoms in hyperthyroidism or thyrotoxicosis will include palpitations. The heart will be beating pretty fast. And of course, what is causing palpitations is tachycardia, right? There'll be tremor, anxiety, and heat intolerance. I know those in medical school who would have clicked on this to get information will be going for heat intolerance, right? In hypothyroidism. Now, in Graves' disease, there will be Graves of dermopathy, infiltrative dermopathy, meaning localized or peritibial mesoedema, and there can be diffuse goiter. The hand. We usually said in physical examination back then when I was in medical school that through the hand you can see the body, that the hand could serve as the window to the entire systems in the body. The same is happening here with hyperthyroidism or thyrotoxicosis. So through the hand, you can see warm skin and erythema, sweating, onycholysis, that is improvement nail. And what's going to happen? There is separation of nail from the nail bed. And then the nails can become thin, so thinning of the nails. Dermatology, we can see hyperpigmentation. That might be pruritus or hips. That may be pointing to Graves' disease. We may see vitiligo. And when there is vitiligo, please note there's likely going to be autoimmune process going on. And when you see one autoimmune condition, you look out for other autoimmune conditions. That may be alopecia areata, also pointing to autoimmune condition. Facial or ocular signs will include stare, lidla, exogenous. There was a time I saw that in a particular patient, not even my patient, but I alerted the physician in charge. It was my MD who was handling the patient back then. Then I told my MD, we're working on this. He said, yeah, yes, actually told the lady. I just saw the lady at the reception. And it was medically, academically fascinating, but I knew that she will be passing through a lot of issues. So that was done. She was told, diagnosis was made. So periorbital edema is possible, conjunctival edema, graftive feelings in the eyes, pain in the eyes, and diplopia. Cardiovascular system will lead to increased cardiac output when there's hypothyroidism or thyrotoxicosis, increased heart rate, that is tachycardia, increased blood pressure, particularly increased systolic hypertension. If you are confused about systolic hypertension, I have a separate presentation here on my channel on hypertension A to Z. That will give you a clue. High output heart failure is a possibility. Atrial fibrillation. This is not most valuable prayer. It is mitral valve prolapse with mitral regurgitation. Increased thrombosis. The musculoskeletal system and hypothyroidism or thyrotoxicosis will lead to increased bone reabsorption, increased calcium, increased osteoporosis, increased fracture, and acropathy, that is finger clubbing. Lipid. Here, there will be low, high-density lipoprotein and low density lipoprotein. Low density lipoprotein that is low is good for us, and low total cholesterol is also good, but we don't like high density lipoprotein to be low. We want it to be high. Hyperglycemia. Why would this lead us to diabetes mellitus? Antagonism to the peripheral action of insulin will lead to hyperglycemia. A respiratory system will be dealing with shortness of breath, pulmonary hypertension, exacerbation of asthma, and increased thrombosis. So we can have pulmonary embolism. Remember, I've talked about the use of calcium channel blockers to handle the rate in asthmatic patients instead of going for non-selective beta blocker. Gastrointestinal tract will not be spared in hypothyroidism and thyrotoxicosis. There will be increased metabolism, leading to decreased weight. To those in the medical school, you'll be so excited to know that there'll be weight loss with hypothyroidism, even with good appetite. Malabsorption will be likely another problem from increased gut motility. And steatorrhea with celiac disease and Graves' disease. Remember, I've said repeatedly in almost all my presentations that when you pick one autoimmune disease, be on the lookout for other possible autoimmune diseases. Good or increased appetite, I've just said it, there's decreased weight despite the good appetite. So the woman or the man is eating, but it's not gaining weight. Well, some will say that's fine, you don't need to gain weight, but it's a disease. Okay? Hyperphagia, with or without enough appetite to lead to weight gain in younger patients. So reverses that here. But anorexia will be the case in older patients. Meaning here, the younger patients will be eating more, and they'll gain weight. But older patients will not even be able to eat that well. They will have anorexia. Weight loss and diarrhea. When there's decreased weight, it's increased metabolism leading to decreased weight is the same as weight loss. Another problem is anemia. Anemia here could be due to vomiting. So when you eat good food, balanced diet, good food, but it's not staying there, it's not even getting down, it's not being absorbed in the system, and there's a problem. Also, because once you find one autoimmune condition, you have to rule out other possible autoimmune conditions. So there may be pernicious anemia. Remember, Graves' disease could be the problem, and when that is the case, you may find pernicious anemia around, giving you megaloblastic anemia, or it might be immune thrombocytopenic purpura, or you've been dealing when you have the laboratory investigation done, you will pick normochromic normocystic anemia. There may be compression from the goiter. Goiter compression effect can lead to dysphagia. Remember, if you go through the anatomy of the thyroid gland, I did not give too much attention to that right here. If you check my presentation on hypothyroidism, I briefly described the anatomy of the thyroid gland. The thyroid gland is there at the anterior portion in the anterior neck. So the esophagus is behind. So when the thyroid gland is enlarged, it's going to rest on the structure at the anterior neck, the trachea, the esophagus inclusive, so leading to swallowing difficulty, known as dysphagia. Thymic enlargement could be big, and that could be only on accidental discovery. Reproductive system. We may be faced with anovullar infertility, meaning there is menses but no egg is being released. And where there's no egg, nothing to be fertilized, so infertility. In hyperthyroidism or Thyrotoxicosis. In men, there may be gynecomastia. And why that? Because there's high likelihood of increased conversion of testosterone to estradiol. Okay, there may be decreased libido and erectile dysfunction from increased estrogen. Okay, here's the point. We're talking about reproductive system. I'm talking about infertility, right? When there's decreased libido in the woman and erectile dysfunction in the man, then you understand without just saying it, what that is telling us. The renal system will not be spared. For example, there will be increased renal frequency and nocturia. So in this case, if care is not taken, we might wrongly diagnose the individual having cystitis or urinary tract infection or diabetes insipidus or diabetes mellitus. So the whole problem is hyperthyroidism here. Now, the psychiatry ward can receive new visitors just because there is hyperfunction in thyroid gland or ectopic thyroid tissues are producing excess thyroid hormone. Because there may be psychosis, agitation, depression, anxiety, irritability, labile emotions, cognitive impairment, and palpitations. The central nervous system can produce tremor with periodic paralysis of thyrotoxicosis, and maybe muscle weakness, and the elderly patient with hyperthyroidism or thyrotoxicosis can present with apathy. Now, the goiter alone. Now, the goiter could be toxic multinodular goiter. In older patients with Graves' disease, they may come down with goiter. Sick sinus syndrome. And someone will ask, what's the business with sick sinus syndrome when we're talking about hyperthyroidism? Okay, don't find me yet. Now, if the laboratory investigations, the thyroid function test parameters, the other signs and symptoms are all pointing to hyperthyroidism, thyrotoxicosis, or even thyroid, and this person is an elderly man or woman, and you are not picking tachycardia, then remember, something might be responsible. It may be due to the underlying sick sinus syndrome in there. Remember, the sinoatrial node is the heart pacemaker, and that is where the electrical activity of the heart will be generated from. So the older we become, that is a tissue. Okay, sinoatrial node is also a tissue, right? So as the older people, we have so many tissues undergoing degeneration. It can happen with sinoatrial node. And when that is the case, instead of propagating and firing repeatedly, it's going to be slow. That's why elderly people will have bradycardia. So if that is the case, if the sinus node is already sick, then tachycardia might not be part of the signs and symptoms that will peak on our examination. So an elderly man or woman not having tachycardia doesn't rule out hyperthyroidism, thyrotoxicosis, or thyroid storm. Should be careful. Might be sick sinus syndrome. That's right there. On physical examination, I will make a video later on physical examinations, and of course, thyroid gland examination will be prominent. So you can wait for that. So for now, we must have general physical examination done, and we have to look for psychosis, physical appearance, vital signs, head and neck, respiratory system, cardiovascular system, gastrointestinal tract, and central nervous system, all systems to be fully examined. And of course, there is a separate pattern to examine for thyroid gland anomalies. Still on signs, on physical examination, we can check the skin, the weight, the gait, the motor and sensory. Should check the reflexes and look at the hand for clubbing, sweaty, anemia, or pallor, including onycholysis. Many meta-state examination will be welcome to ascertain whether there is cognitive impairment or not. Remember, I've said earlier that there may be psychosis. Now, differential diagnosis. How do you mean? Oh, yes. Sometimes you might think it is hypothyroidism and it may be not. So if it is not hypothyroidism, then what can it be? The differential diagnosis of hyperthyroidism or thyrotoxicosis. Could be high glucocorticoids, could be dopamine, could be beta agonist, giving the tremor, epinephrine giving the tremor, levothyroxine. Yeah, when you are treating hypothyroidism and you give the T4 and then the patient has taken it in large quantity or prescription from the beginning as given a very high dose of levothyroxine, then it could be the problem that we're dealing with right now. Maybe pregnancy with a drop in thyroid stimulating hormone. So when we do the thyroid function test and we find TSH to be low, T4 and T3 to be high, if this woman is a woman of childbearing age, please let us have woman gonadotropin also done, because pregnancy can lead to drop in TSH. Post-traumatic stress disorder, panic attack, fever, and fear, all these could give us the signs and symptoms of hyperthyroidism. As a matter of fact, when there are features suggestive of panic attack, we have to rule out hyperthyroidism and hypoglycemia as part of the differential diagnosis. Might be dehydration. Okay, there might be hypoglycemia, might be hypovolemic shock because of the presentation, right? Might be goiter when there's swelling there, or Graves' disease, or Struma ovary, or Thyrotoxicosis imaging. Maybe just arrhythmia from another source entirely that has nothing to do with the thyroid gland. There are many things that could cause arrhythmia. Still on differential diagnosis, there may be euthyroid hypothyroidism. There may be abnormal serum thyroid binding immunoglobulin, leading to increased serum total hormones, increased free T4, slightly increased or normal T3, normal thyroid stimulating hormone, and euthyroid. Still on differential diagnosis, it might be T4 toxicosis. And how do I mean? It means we have T4 in excess giving us trouble. T4 level will increase without T3 if we have amiodarone in the system, because amiodarone can prevent T4 conversion to T3. So the T4 is just sitting down there, accumulating, and not being peripherally converted to T3. So with decreased T4 conversion to T3, then we have T4 toxicosis. With decreased T4 conversion, we have more of it. Then in non-thyroid illness, because peripheral conversion of T4 to T3 will happen peripherally. So if there's problem with the liver, with the gallbladder, with some parts of the pituitary, with the skin, with ear, and parts of the brain, T4 will not be converted to T3. Then T4 will tend to accumulate and give us T4 Tosic Causes. It might be TSH-induced hyperthyroidism. Remember, the hypothalamic pituitary thyroid axis, the Thyrotropin-Releasing hormone is coming from the hypothalamus, then will be stimulating or acting on the anterior pituitary to produce thyroid-stimulating hormone. This hormone, thyroid-stimulating hormone, is expected to act on the thyroid gland, stimulate thyroid gland, induce thyroid gland to be producing thyroid hormone. So, if thyroid-stimulating hormone is high because of pituitary adenoma or partial resistance to the feedback effect of T4 and T3 on thyroid-stimulating hormone secretion, then there will be more TSH that will be sending signal to thyroid gland, telling the thyroid gland to start producing more of T4 that will be converted to T3, although some level of T3 will also be produced. Here now, we expect high level of T4 to give negative feedback that will stop further release of TSH. But if there is resistance to that feedback, then the high level of T4, even in T4 toxicosis, will not alter or reduce the production of TSH. So the TSH will continue to be released regardless of the value of T4, because that negative feedback is not working on TSH secretion right now. Now, the diagnosis. We have gotten to a big bus stop right now. The diagnosis of hyperthyroidism or thyrotoxicosis or thyroid. This will not be anything too new to you, but we are getting down to the root of the problem. Let's go. Now, the diagnosis will start with thorough history, full physical examination, and laboratory investigations. We'll have thyroid function tests done and some radiological investigations. Now, when we have done everything, we are likely going to come down with certain definitive diagnoses that could be responsible for the thyrotoxic causes. It might be overt thyrotoxicosis, so clinical thyrotoxicosis, might be toxic nodular goiter, could be Graves' disease, or autoimmune thyroiditis. In overt thyrotoxicosis, the thyroid function test will reveal decreased thyroid-stimulating hormone, increased T4, and increased T3. In overt hyperthyroidism, we will see increased or normal radioiodine uptake with decreased TSH that will be less than 0.05 milli-international unit per liter, increased T4 and increased T3 in overt hyperthyroidism. In subclinical thyrotoxicosis, something different will happen. TSH will be decreased like we found in thyrotoxicosis and hypothyroidism, but instead of very high T4, it's going to be normal. Instead of very high T3, it's going to be normal. So it's going to be subclinical thyrotoxicosis because even the parameters here will not be giving us classical picture of thyrotoxicosis, and of course the signs and symptoms will not be the same. Subclinical hypothyroidism will have low TSH, but this time around it will be greater than 0.05. Remember, overt hyperthyroidism will have TSH that will be lower than 0.05. And we'll expect in overt hyperthyroidism that T4 will be high and T3 will be high, but in some clinical hypothyroidism, T4 will be within normal range, T3 within normal range, and the clinical signs and symptoms of overt hyperthyroidism will be absent here. But even when certain symptoms are present, it will be very mild. So will not lead to running around helter-skelter to save this patient, or in any shape or form, it's not going to affect the normal daily activities of this individual. And lipid. We will check the lipid level and we will find decreased total cholesterol, decreased LDH, and decreased HDL. Like, I love it that we have decreased LDL and decreased total cholesterol, but I want HDL to be higher. In hematology, we'll pick normochromic normocystic anemia. Osteocalcine. There will be increased alkaline phosphatase and increased osteocalcine. In thyrotoxicosis caused by Graves' disease, that is also known as T3 toxicosis. Could be a nodular goiter. Here we'll find more T3, okay, less T4 increase. And the question we should ask ourselves is, where is the T3 coming from? Okay, T4 conversion to T3 is increasing, okay, but at a point, this will correct itself, I think, if the patient is still alive anyways. And why am I thinking like that? Or my thinking is irrational? Okay, let's think about it. Whether from the real thyroid gland or ectopic thyroid tissue, T4 is being synthesized and secreted, right? Okay, and peripherally, T4 is being converted to T3. One way or the other, T4 must be present before we can get T3. If something should happen that will have less of the T4 being, produced, then regardless of how efficient the conversion or how fast or how quick or how great the conversion of T4 to T3 is, there'll be a time that without more of T4 being produced, there'll be end to T3 in the circulatory system because we won't get T3 from T4 anymore. But something will continuously be persistent. I mean, there will be low TSH, progressively. Now, another scenario is critically ill non-thyroid illness. Here, remember that T4 will be converted to T3 at the peripheral level. So we have said critically ill, the patient is becoming moribund, but the illness has nothing to do with the thyroid gland. So T4 is being produced maybe normally or correctly within the normal range by the thyroid gland, but other tissues responsible for the peripheral conversion are in trouble right now. So what will happen when T4 is there but is not being converted to T3? So in non-thyroid illness, patients that are critically sick will have problem with that peripheral conversion. They'll be dealing with decreased binding of T4, even where it should be bound, and decreased thyroid binding globulin. Of course, these two are saying the same thing. And there may be displacement of T4 by the medications we'll be using to handle the critical or moribund illness that's on ground. And then we will find normal level of T4 or decreasing level of T4. For sure, there will be decreasing level of T3. T3 will be low because the liver is sick, the gallbladder is sick, part of the brain is sick, part of the thyroid gland is sick, the skin, the ear, all different parts of the body responsible for the conversion of T4 to T3, they are sick because this patient, he has critical illness. It's moribund. Okay, so T3 will be low. Okay, and then decreasing thyroid-stimulating hormone. Thyroid-stimulating hormone here will be pretty low as less than 0.01 milli-international unit per liter in non-thyroid illness alone. Now, biotin effects. Biotin will interfere with thyroid function test for sure. I have a separate presentation on that. Biotin is not only inimical to normal investigations as per thyroid hormones, but also in acute heart attack, we can wrongly clear somebody who has heart attack because troponin will be down. Troponin I and troponin T will be down. And so we will think they are not raised when biotin, ingested conditions. So there'll be drop in TSH with increased T4, increased T3 in anyone who are taking biotin. So this will give us the picture of hyperthyroidism. But the individual may not actually have hyperthyroidism. So the best thing to do is to stop the test if we have taken the history of biotin use. Don't do the test now because of biotin. That will not give you the true picture, because what you're going to do in the face of hypothyroidism would be too horrible if the patient is actually not having hypothyroidism. So stop biotin, repeat this test in 2 to 4 days. I'd rather choose the next 3 days. Thyroid radioiodine uptake is going to be raised in Graves' disease. It will be normal or raised in toxic molecular goiter. It will be low or even undetectable when we give levothyroxine exogenously, either because we are treating hypothyroidism or the individual has accidentally ingested levothyroxine, or factitious disorder were deliberately taken to cause medical scenarios that will attract sympathy and so on. So low or undetectable also in thyroiditis, at the thyrotoxic phase. The scan. There will be diffuse uptake in Graves' disease. Focal area of uptake would be the case in toxic mononuclear goiter. Thyroid-stimulating immunoglobulin. Thyroid-stimulating immunoglobulin will increase in Graves' disease. The thyroid peroxidase. There will be increased thyroid peroxidase antibody, and that will be pointing to autoimmune condition. Now, the definitive diagnosis, meaning there are certain things we can do that will bypass the hurdles of being careful about biotin or non-biotin and all this stuff, and will lead straight to the right diagnosis of hyperthyroidism or thyrotoxicosis. One of such is radioactive iodine uptake with scan. But we cannot do this if the woman is pregnant. In other words, it is contraindicated in pregnancy. As a matter of fact, in any woman of childbearing age, we must rule out pregnancy before embarking on this. How do we do that? Woman chronic gonadotropin first, and we'll get our values and be sure the woman is not pregnant. Then we can embark on radioactive iodine uptake with scan. We can have thyrotropin receptor antibodies done for pregnant women, because somebody is already asking me that if you are saying you cannot use radioactive iodine uptake and scan in pregnant women, then what do you do? Then you can use your thyrotropin receptor antibodies for pregnant women. You can also use that in non-pregnant women. So in non-pregnant women or men who have radioactive iodine uptake and scan, you have thyrotropin receptor antibodies. Not applicable with goiter or Graves' disease. Of course, you can have your odds. If you are still confused after you've done everything, you are not sure you are making the right diagnosis, or you are pretty careful not to label someone as being hyperthyroidic or having hypothyroidism, or you don't want to clear somebody because you are not sure the individual is not having it, then do you know what to do? Repeat the test in 2 months. Repeat the test in 2 months. Then your conscience will be clear. And of course, your license will be intact. Okay, we are now at the very big bus stop, that is the treatment of hypothyroidism Thyrotoxicosis. You made the correct diagnosis, right? Okay, what are we going to do? And to those who are affected, we want to know if you're on the right track. Yes. Let's go. The treatment of hypothyroidism or thyrotoxicosis will involve antithyroid drugs, that is, thionymus, radioactive iodination therapy. We may call for thyroidectomy depending on the source of the thyrotoxicosis. If it's directly from the thyroid gland, thyroidectomy could help. But if it is from ectopic thyroid tissues in other parts of the body, then we'll address that as it may be appropriate. Beta blockers to handle the adrenergic symptoms and change in lifestyle. Now, the beta blockers, that will take care of adrenergic symptoms. And the adrenergic symptoms here will be palpitations, tachycardia, tremor, anxiety, and heat intolerance. So the beta blockers will handle that. So we'll start early in the diagnosis and until a complete resolution is reached. You can make use of propranolol in a very high dose, around 160 mg per day. Beta blockers can also decrease T3 concentration by up to 30 to 40%. We can also make use of atenolol. Metoprolol will also decrease T3. Sotalol and Nodolol won't decrease T3. Better with metimazole, meaning we are going to achieve better or get better outcome if we use beta blockers with metimazole. What are the possible contraindications to the use of beta blockers? Hypersensitivity to that particular agent means we're not going to make use of it right now. There's likelihood of heart block, particularly in elderly with sick sinus syndrome or bradycardia. Be careful with the use of beta blockers. Also in asthmatic or patient with chronic obstructive pulmonary disease, be careful with the selection of non-selective beta blockers. In severe peripheral vascular disease, we have to be careful. In fact, I will not use it. Also in renal phenomena. In hypoglycemia, beta blockers can mask the adrenergic symptoms, like it has already been said and already been published by me. You can check my channel for diabetes mellitus A to Z. There I stated that when there's hypoglycemia, the first set of symptoms to manifest will be adrenergic symptoms. Those adrenergic symptoms can be blocked when an individual is already on beta blockers, and the individual could die of hypoglycemia unaware. So there's that entity called hypoglycemia unawareness. Thyrotropin-Releasing. Thyrotropin-Releasing will include metimazole, carbimazole, and propyltyruracil. Thyrotropin-Releasing like propyltyruracil and metimazole. Metimazole is common in US, Canada, and Mexico, while carbimazole is common in Europe and Asia. The carbimazole is metabolized to metimazole. Propyltyruracil decreases conversion of T4 to T3, while metimazole is used once daily. Propyltyruracil will require multiple daily doses. Still on thyrotropin-Releasing, thyrotropin-Releasing are often started in Graves' hyperthyroidism to lead to euthyroid position, usually helpful before radioiodine therapy and before thyroidectomy. The treatment for 3 to 6 weeks or more may be required with the thyrotropin-Releasing. Contraindications to thyrotropin-Releasing. When there's hypersensitivity to any of those agents, we don't use it. In the face of agranulocytosis, we will keep thyrotropin-Releasing off the table. Hepatotoxicity or pregnancy, no thyrotropin-Releasing usage. Propyltyruracil, when compared to metimazole, will go to the following. So, propyltyruracil, when you compare that to metimazole, propyltyruracil will be slower. There will be more hepatotoxicity or vasculitis with propyltyruracil, and worse compliance because some patients will need it multiple times in a day. It will decrease the effects of radioiodine outcome. But propyltyruracil is better than metimazole in pregnancy. And also propyltyruracil will be better in life-threatening thyrotoxicosis or thyrostorm. So in thyrostorm or life-threatening thyrotoxicosis, we should rather go for propyltyruracil when compared to metimazole, but it has its own baggage as well. Now, metimazole or propyltyruracil, know this. Metimazole is used more than propyltyruracil. we can administer that through rectum, intravenous, or per oral. And of course, we have to do liver function test, thyroid function test, and complete blood count. Glucocorticoids. Glucocorticoids will relieve anterior neck pain in thyroiditis. Remember, glucocorticoids will be serving as an inflammatory agent here, where thyroiditis is an inflammatory process. Glucocorticoids will inhibit conversion of T4 to T3 in the phase of thyroid storm. Then there is an entity, an inorganic iodide. SSKI is an example that is a brand name or Lugol solution. This will decrease the synthesis of thyroid hormone and the release of the same. In thyroid storm or pre-thyroidectomy, we make use of inorganic iodide. It will be helpful in these situations, but we'll talk more about this in a bit. Iodine in the treatment of thyrotoxicosis. A potassium iodide solution was formerly used for the treatment of goiter and Graves' disease. You could see rating formerly used, meaning not more or no longer so. Why that? It has been considered to be dangerous. And why will you call something dangerous? If the particular agent is not truly dangerous, that's going to be bad, but let's check. There may be metabolic acidosis with the use of potassium iodide. There may be hypotension, renal failure, and the patient could die. Is that not dangerous? It is dangerous. So because of this, it's now having just a minor role in the treatment of hypothyroidism because we are running away from metabolic acidosis, hypotension, renal failure, and death. So potassium iodide solution is useful in the face of thyroid storm. It is an adjunct to thionamines, adjunct to radioiodine therapy, and helpful in pre-thyroidectomy. The iodine. It will appear in form of potassium iodide solution. And I don't want to rush through this very page because on the previous slide, we've just gone through the fact that it could be dangerous, given metabolic acidosis, hypotension, renal failure, and even death. So, with that, it depends on what we want to use it for, and that will determine the number of drops and the number of times we'll use it in a day. Like, it's not the same dosage when it comes to pre-thyroidectomy or thyroid storm or radioiodine therapy or in hyperthyroidism. So let's go through. Now, a drop will be 50 milligram iodide, and that would be 0.05 ml. Now, in pre-thyroidectomy, we will use 1 drop 3 times daily for 10 days or 2 drops 3 times daily for 10 days in pre-thyroidectomy. After that, you embark on your surgery. In thyroid storm, because we're in the storm, right, we will use 5 drops 4 times daily. And when it is about radiotherapy, radioiodine therapy, we'll use 3 drops 2 times daily for 7 days after radioiodination. And if it is all about hypothyroidism not involving all this, we'll use only 1 drop once a day in hypothyroidism. Also, in another form, which is potassium iodide tablets, or C, the Lugol solution. The Lugol solution will use 6.25 milligram iodide per drop. And in that case, we will use 5 to 7 drops 3 times daily for 7 days if our target is pre-thyroidectomy, and 10 drops 3 times daily for thyroid storm. Iodinated radiocontrast agent. This could be used with metimazole. Iodinated radiocontrast agent can also be useful in levotyrosine overdose. Iodate and hyaluronic acid should not be used as monotherapy in patients with Graves' hypothyroidism or in individuals with Tosic adenoma or Tosic mononuclear goiter. Radioactive iodine. We have 131 iodine, useful in Graves' disease and Tosic nodular goiter. Within 8 weeks, you can achieve 85% euthyroid state. Only few doses will be required of the radioactive iodine. This will reduce thyroid size by 40% in Tosic mononuclear goiter. But be careful, it's likely going to lead to hypothyroidism. Hyaluronic acid. This is oral cholecystographic agent. It is rich in iodine. It can decrease the synthesis and release of thyroid hormones. It's going to inhibit the conversion of T4 to T3. The short-time use in thyroid storm is welcome. With rapid preparation for thyroidectomy, the hyaluronic acid is also welcome, but it is not effective as a long-term therapy. So we can say oral cholecystographic agent. Okay, so it's going to decrease the synthesis and release of thyroid hormones. It's going to inhibit conversion to T3, so thyrotoxicosis will be on the downward trend, right? But good for short-term use in thyroid storm. And if you are in a hurry to prepare for thyroidectomy, you can grab that. But using it for long-term therapy is out of place. Iodine mechanism of action. The mechanism of action is such that iodine will invade hormonal secretion within hours. That's why we can use some of them for rapid preparation, for short time, in thyroid storm, and so on. It inhibits iodine organification. If you have gone through my presentations on hypothyroidism and also on iodine action in thyroid hormone synthesis, you would have gotten the clearer picture of iodine is inevitable in the synthesis and subsequent secretion of thyroid hormones. Decreasing thyroid hormones by synthesis or a Wolff-Chaikoff effect is one major mechanism of action of iodine. It can decrease thyroid hormone biosynthesis, a phenomenon known as Wolff-Chaikoff effect. Contraindication to iodine. In Tosic adenoma or Tosic mononuclear goiter, iodine may actually promote hyperthyroidism. So we should be careful about that. Now, side effects of 131 iodide. There may be radiation thyroiditis, anterior neck pain. Initially, it can worsen the thyrotoxicosis. Therefore, pre-treatment with thyronamides will prevent this. So we can give metimazole ahead before using the radioiodination therapy. Propylthiouracil is not good with 131 iodide. That is why when I was giving the example of thionamides that could be used before radioiodination, I did not mention propylthiouracil. I said metimazole. Why that? Propylthiouracil is not good with 131 iodide. So metimazole, carbimazole will be welcome. And you can administer metimazole or carbimazole for 3 to 5 days before you administer your 131 iodide, meaning before radioiodination. Still on the possible side effects, graves of thermopathy may worsen in individuals that will be smoking and also in those with severe hyperthyroidism. Radioiodination is relatively contraindicated in children and adolescents, but in pregnancy, it is absolutely contraindicated. Let me repeat this page. Okay. In graves of thermopathy, it may worsen. That is, graves of thermopathy could go down the hill in smokers and those with severe hypothyroidism. Relatively contraindicated in children and adolescents, but absolutely contraindicated in pregnancy and lactation. Now, when it comes to thyroiditis, if it is thyroiditis, there will be decreasing radioactive iodine uptake. Beta blockers will be helpful, and glucocorticoids will be the drug of choice here. Surgery. Surgery will be necessary in Graves' disease with a large goiter. Also, goiter causing airway obstruction, then we'll go for surgery. Surgery will be helpful for histological and pathological studies. You can, exercise then send for that, find into aspiration cytology and so on. It needs parathyroidectomy at the same time. Moderate to severe graves of thermopathy will require surgery. Pregnant women who can take Thionemas, but they can take propyltyrosine, can have surgery, but that should be in second trimester. So we'll not have that in a pregnant woman in first trimester. When there is failed Thionemas, you've used a metimazole, carbimazole not winning, then we go for surgery. You may use a propyltyrosine depending on what you are dealing with. In failed radioiodination, then you embark on surgery. So surgery is indicated in all these situations. Okay, what are the possible contraindications to surgery? Because it's not everyone that could be willed to the theater and have the anterior neck, operated upon. So a pregnant woman will have relative contraindication, not absolute contraindication. The reason is if we are able to explain the risk, like spontaneous abortion or premature delivery, preterm delivery, and so on, and the woman says, okay, that's fine with me, then you can take the risk. But if it's a precious pregnancy, precious baby coming on the way, for example, a family that would have waited for a long time to have the pregnancy, then maybe you can find your level. But if it's seriously affecting the woman, and you need to choose between saving the life of the unborn baby and the mother, rather save that of the mother. In the face of severe cardiovascular disease, you need embark on surgery. Why that? No, you know what surgery will entail, right? In severe pulmonary disease, the anesthetic agent, even the anesthesiologist will not even agree with you. Of course, anesthesia concerns. So in pulmonary disease, cardiovascular disease, anesthesia concerns will form the basis of refusal to proceed with the surgery. And even the phase of anesthesia itself in certain patients. Thyroidectomy, that is the surgery, right? So that will cure hyperthyroidism in about 90% of the cases of the people that will embark on this. It will decrease the pressure effect of goiters, like dysphagia, and then breathing difficulty and so on. It's only a full thyroidectomy is only welcome in second trimester of pregnancy. There may be damage to recurring laryngeal nerve. And how are we going to know? The affected person will have hoarseness that cannot be reversed. There may be permanent hypothyroidism in 1 to 2%, particularly in those with uh, total thyroidectomy. Hypocalcemia may occur for a while because when thyroidectomy is done, the good neighbor, the parathyroid glands, could be excised as well. So in that case, the thyroid gland is gone, the parathyroid gland is also gone, although they function independently of each other, but the close proximity will lead to adverse effects. When thyroidectomy is embarked upon, the parathyroid gland will inadvertently be excised as well, and that will lead to hypocalcemia. And may be bleeding. Of course, any surgery can lead to bleeding, but then the thyroid gland is well vascularized, So taking the source of blood supply, you can trace the brief anatomy that I have presented um, through my A to Z presentation on hypothyroidism. Still on thyroidectomy, there may be infection and permanent hypothyroidism in many people. Leakage of thyroid hormone into the circulatory system during the surgery can cause a severe thyrotoxicosis briefly. Okay, like the cases with thyroiditis that is going to scoop into the thyroid gland and then push the content of the thyroid gland to the circulatory system. This same thing is close to that here when the surgeon places the knife and then the thyroid gland is open now, thyroid hormones will be released and then we'll be battling with thyrotoxicosis, but it's not going to be for a long time. We can use thionamides before surgery to prevent thyrotoxicosis, okay, so that we can have euthyroid state. SSK or Lugo solution can be used 10 days before surgery in Graves' disease to decrease thyroid vascularity. Subclinical thyrotoxicosis. There is a self-representation on subclinical hypothyroidism, and I figured out a kind of debate on that and then published that. And I like put both argument for and argument against the use of levothyroxine in subclinical hypothyroidism. You can check my channel for that. You have that presentation. Now, subclinical thyrotoxicosis, the treatment here is subjective, depends on who you're talking to. But my big advice here is involve your endocrinologist in your jurisdiction. In subclinical thyrotoxicosis treatment, the best advice is when thyroid-stimulating hormone is less than 0.1 milliliter unit per liter, that warrants treatment. But whatever I may say here will be superseded by whatever your endocrinologist will advise. So contact the endocrinologist in your jurisdiction. When you do that, that will decrease atrial fibrillation, will also decrease osteoporosis in postmenopausal women. We can measure thyroid-stimulating hormone while on treatment in subclinical thyrotoxicosis, and then we'll stop the treatment when thyroid-stimulating hormone is within normal range. Can also use low doses of thionamides because it's subclinical, so there's nothing to rush about here, but is not to be ignored. Okay, we don't need radioiodination here. No, we don't need that. We don't need radioiodination therapy here. No. Now we are going to the end of this presentation, and we want to address complications because we've been talking about thyrotoxicosis, thyroid storm, hypothyroidism, Graves' disease, how to make diagnosis, getting around the treatment, achieving euthyroid state, and so on. What are the possible complications that we can run to? So let's get down and enter the house of complications of hyperthyroidism and thyrotoxicosis. Now, in thyrotoxicosis or thyroid storm, there will be diaphoresis, heat intolerance, diarrhea, fever, fatigue with muscle weakness, tachycardia, and confusion. And maybe arrhythmia, nervousness, irritability, increased appetite, weight loss, and anxiety. You know what? When there is arrhythmia, the heart is not pumping the blood appropriately, it's quivering. And then there will be stasis that will lead to thrombus formation. And we know the implication of that. It can be stroke from arrhythmia, heart failure, and so on. All this will occur with arrhythmia. I may be seizures, some, and delirium. Arrhythmia, for example, atrial fibrillation, I've mentioned that before. There's likelihood of heart failure, particularly from arrhythmia, okay? Maybe stroke, maybe coma, and of course, death. In hypothyroidism, there may be Graves' dermopathy, maybe osteoporosis, hypertension, menstrual irregularities, and infertility. So, a woman of childbearing age with hypothyroidism should not be ignored or overlooked because she will come down later on with infertility, most likely. And there will be hypertension. And when she's pregnant with hypertension, we know pre-pregnancy hypertension or pregnancy-induced hypertension, we don't want either for any pregnant woman. And Graves' dermopathy, osteoporosis, and of course, menstrual irregularities. So, when there's menstrual irregularities, it is not out of place to have thyroid function tests done. Still, the complications of hypothyroidism, there may be photophobia and swollen or bulging eyes, diplopia, blurred vision, and blindness. In other words, the ophthalmologist will be involved in hyperthyroidism because of ocular complications. Still, in hypothyroidism, we may be faced with atrial fibrillation just as in thyroid storm or thyrotoxicosis, stroke just as in thyroid storm or thyrotoxicosis, because once there's atrial fibrillation, the atria right and left are just quivering. They are not actually contracting, they are not actually pumping the blood. So there will be stasis. And then thrombus formation will be the case, leading to stroke. There may be dilated cardiomyopathy and congestive cardiac failure. So all this will lead to the probability of cardiac arrest and sudden cardiac death. In all, early and accurate diagnosis will reduce possible complications, including preventing death here. You can pause, rewind on how to make accurate diagnosis from history to physical examination, radiological investigations, thyroid function tests, and so on. Radioactive iodination is the best treatment for hyperthyroidism, but not in everyone. Relative contraindication, absolute contraindications, pause and rewind, you get there. Then, certain medications like thironamines, beta blockers, glucocorticoids, when are they helpful? Which ones are you not going to use in certain situations? You can pause and get there. Stop words should be stopped, and start words should be started. In grades of thermopathy, orbital decompression and eye muscle therapy will be pretty helpful. With that, I've come to the end of this lengthy presentation on hypothyroidism. But 2 hours plus is okay to know what hypothyroidism, thyrotoxicosis, and thyroid storm is all about and how to get out of them. Thanks for listening. Remember to subscribe to my channel if you haven't. Remember to share this presentation on your platforms. Let's help human race. I appreciate it.